Assalamualaikum students. So today we will discuss the key to questions of GIT module of the anatomy. The question was, a 60-year-old man visited a medical consultant with complaint of abdominal discomfort and nausea after meals. Physical examination revealed slightly enlarged liver without tenderness. Lab investigations showed raised liver enzymes. Doctor suspected accumulation of fat in the liver. Keeping in view the concept of structure and function of liver, give the histological structure of the hepatic lobule. Where would you consider the accumulation of fat is, and is it reversible? And give the location and function of the hepatic stellate cells, that is the I2 cells. Answer to the first question, that is the hepatic lobule, structure of hepatic lobule. So you can see in this picture a hepatic lobule is being drawn here. It is a six-sided structure. So it is a hexagonal, hepatic lobule is hexagonal in shape. So it is hexagonal in shape. Hepatic lobule is hexagonal in shape, and on each corner there is a hepatic portal area, portal triad or portal area, which contains the branch of the portal vein, tributary of the bile duct, and branch of hepatic artery. So you have to write the branch of every structure, not the structure itself. So in the center there is the central vein, and radiating from this central vein are the cords of hepatocytes, and you can see these are the single layered column of cords of the hepatocytes, and in between them lie the sinusoidal spaces, sinusoidal capillaries. So you can see the endothelial lining of the sinusoidal capillaries. Also lining in these capillaries are the Kupffer cells. So nuclei of Kupffer cells are also visible. And so this is how you have to draw the classical hepatic lobule. Where is the fat accumulated? Fat was accumulated in the hepatocytes, and this fat accumulation is reversible. Now the question of the space of the I2 cells or the stellate cells. Now these cells, this is a picture of the hepatic lobule in which this is a central vein, and from this central vein is mediating the cords of hepatocytes. You can see these are the cords of hepatocytes, and in between the cords of hepatocytes lie the sinusoidal capillary space. And you can well observe here the endothelial cell, the Kupffer cells, and in between the endothelial cells and the hepatocytes lie the space of Deci. So this is space of Deci. These I2 cells, these are the I2 cells or stellate cells. These are present in this space of Deci, and they normally function to store the vitamin A along with some fat, but in abnormal conditions they change their morphology into a fibroblast and they secrete collagen fibers. So fibrosis in the liver is caused by these I2 cells. A child was born with large defect of the umbilicus. Second question was, a child was born with large defect of the umbilicus. Most of the large bowel protrude through the defect and covered by amnion. So this condition is diagnosed as omphalocele. So this was the question. Now they were asking, what is the embryological basis of omphalocele? Mention the differences between omphalocele and umbilical hernia, and write about the various steps of development of the midgut. This defect is attributed to the failure of gut loops to return to the body cavity after their normal physiological herniation into the umbilical cord from 6th to 10th week. And an umbilical hernia is completely covered by the skin, unlike an omphalocele, which is covered by a thin translucent membrane, which is the amnion. So these are the pictures. You can see the This is the umbilical hernia, and it is produced due to a defect in the wall of the abdomen, weakness in the wall of the abdomen at the area of the umbilicus, and you can see that it is covered by the skin. Now this is the omphalocele. Here you can see the coils of the intestine and also the liver, and it is covered by an amnion. So formation of midgut loop. So steps in the formation of midgut loop. It starts in the 4th week. Midgut region undergoes rapid growth, resulting in formation of a loop that protrudes into the umbilical cord. Now as it elongates and it herniates, there is a rotation of the midgut loop 90-degree clockwise around the superior mesenteric artery axis. This rotation brings the cranial part of the midgut loop to the right side of the embryo and the caudal part to the left. Now herniation of the midgut. With the elongation and rotation of the midgut loop, there is herniation of the midgut loop into the umbilical cord. This herniation occurs due to limited space within the abdominal cavity at this stage. Now return of the midgut loop in the abdominal cavity. By the end of 10th week, as the abdominal cavity enlarges, the herniated midgut begins to return to the abdominal cavity. Now this process occurs in cephalocaudal fashion, with the cranial portion returning first. Reduction of the midgut. As the midgut returns to the abdominal cavity, it undergoes a process known as reduction. During reduction, the midgut loop assumes its final position within the abdomen, and its blood supply becomes established through the superior mesenteric artery. Then the formation of the various parts of the midgut and differentiation of the various parts of the midgut, and then the blood supply and innervation. Now, 56-year-old man presented with acute abdominal pain and obstructive jaundice. Radiographic studies revealed the tumor of head of pancreas. What would be the cause of obstructive jaundice in this case? Give relations and blood supply of the head of pancreas. What is hepatopancreatic ampulla and where does it open? Name its sphincter. So, another question is asked in this respect: why the cancer in the head of pancreas is common? Why not in the body, tail or the neck? So I will tell you later. So here you can see the carcinoma of the head of pancreas, and here the bile duct is opening into the second part of the duodenum. Now this pancreatic cancer is obstructing this bile duct, causing the obstructive jaundice. Now the relations of the head of pancreas: anteriorly transverse mesocolon and transverse colon is lying, and the lesser sac; posteriorly inferior vena cava, right renal vessels and common bile duct. On the superior border of the head of pancreas lies the first part of the duodenum and superior pancreaticoduodenal artery. On the inferior border, third part of the duodenum, inferior pancreaticoduodenal artery, and at the right lateral border, second part of duodenum, terminal part of the bile duct lies. Now what is hepatopancreatic ampulla? Here you can see that the bile duct and the common hepatic this bile duct and the pancreatic duct combining to form a structure which is known as hepatopancreatic ampulla, which is opening up into the major duodenal papilla, a summit in the lining of the duodenum, mucosa of the duodenum, where this is opening. And the sphincter of OD is the sphincter. This is the sphincter of OD, which acts as a sphincter for this hepatopancreatic. Please tell me in the comment section why pancreatic cancer is more common in the head region.